Good afternoon, everyone. Welcome to the Gain Center's national webinar on screening and assessment of co-occurring mental and substance use disorders for justice-involved populations. This is a part one webinar on this topic, and today we're doing an overview of evidence-based tools and approaches across the Sequential Intercept Model. I am Dr. Melissa Stein, Senior Research Associate with Policy Research Associates, and I have just a couple of housekeeping remarks. First, the views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies for the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Throughout the webinar, we welcome your questions. As you'll see on the right side of your computer screen, there is a Q&A pod. Just click on that. It will expand, and you can enter questions at any time throughout the presentations. We will be addressing the questions, as many as we can, at the end of the presentations. We also will have some polls popping out throughout the webinar, and we really appreciate your participation in these polls. The webinar is being recorded, and we will be sending slides directly to anyone who is registered for this webinar, as well as through the GAIN's national listserv. We will also let you know when the webinar recording is available. And at the end of the webinar, we have a certificate of attendance which will be available for download. And this is just for personal use. We are not able to offer CEU credits at this time. Just a brief look at the agenda. We have Roxanne Castaneda providing some opening remarks. Dr. Roger Peters and one of our own, Travis Parkers, will be presenting on this issue. And then we will end with some time for Q&A. But first, I'll turn it over to Roxanne for some opening remarks.
Thank you, Melissa. Hi, my name is Roxanne Castaneda, and I'm actually the lead for early diversion here at SAMHSA and the criminal justice lead for the community support programs for CMHS. Dr. Lark Wong, who's the director of the Office of Behavioral Health Equity and Justice Involved, oversees criminal justice projects across SAMHSA, was not able to be with us today, but she's left some opening remarks to share that I'm going to read. On behalf of the Substance Abuse and Mental Health Services Administration, we'd like to welcome you to this webinar. SAMHSA has a priority focus on the intersection of the behavioral health and criminal justice systems. We know that people with mental and substance use disorders are overrepresented in the criminal justice system, with estimates of 44% of people in jails and 37% in prisons with a mental health disorder, and estimates of nearly 63% of people in jails with a substance use problem. Our focus at SAMHSA is to divert these individuals from arrest, jail, and prison, to connect them to treatment and supports, and for those incarcerated to promote successful reentry to community living. This involves critical partnerships between behavioral health and justice personnel to identify these individuals, assess their level of need, and develop the appropriate dispositions which take into consideration both the clinical and social needs of the individual and the public safety needs of the community. Essential to this task is knowing and accessing the most important screening and assessment tools. However, the task is more complicated, as it is not just screening for mental and substance use conditions, but screening for criminogenic factors, those that put someone at risk for reoffending. This is the focus of part two of the webinar. Gaining familiarity with screening and assessment in the justice system, identifying and selecting the most appropriate instruments, knowing when to screen, and having a schedule of screening and assessment that will inform dispositions is all more complex in a system that, unlike a healthcare system, is not set up for this activity. SAMHSA has developed a document that will be presented in part one of the webinar, which includes a compendium and description of available screening and assessment tools. Today, part one of the webinar will present issues regarding screening and assessment and an introduction to the various instruments and key questions to consider at different points in the justice system. What does screening look like at pre-arrest with law enforcement, at initial detention and court hearings, at jail booking, and re-entering the community? Part two will provide concrete examples of places that have successfully implemented screenings and assessment into the flow of the justice system. We are very pleased that you have joined us for this webinar and are confident that the information will be more than informative, but doable, feasible, practical, and will contribute to the best dispositions and outcomes for people at the intersection of behavioral health and criminal justice. Thank you. And now we'll turn it over to Melissa.
Thank you, Roxanne. And now I'd like to just do a brief introduction of our presenters today. We are happy to have Dr. Roger Peters with us. He is a professor in the Department of Mental Health Law and Policy at the University of South Florida, and he has extensive research and clinical expertise in substance use disorders, co-occurring disorders, and behavioral health treatment within the criminal justice system, as well as extensive expertise in evaluating substance use disorders and co-occurring disorders in the criminal justice settings. He serves on the Florida Supreme Court Steering Committee on Problem-Solving Courts and is a faculty member of the National Judicial College. And previously, he served 4 years on the Board of Directors for the National Association of Drug Court Professionals and 8 years on the Treatment-Based Drug Court Steering Committee for the Supreme Court of Florida. Travis Parker is a Program Area Director at Policy Research Incorporated, and he has extensive experience as a provider of substance use and mental health services in correctional facilities and other settings. Previously, he served as a Vice President of System Transformation, Tribal Liaison, and Director of Clinical Services at Magellan Behavioral Health of Nebraska. He's formerly served as a Deputy Director of the Community Mental Health Center of Lancaster County, Nebraska, and formerly was a Program Director for the Behavioral Health Jail Diversion Program and Departments of Emergency Services, Homeless, and Special Needs at the Community Mental Health Center of Lancaster County. So without further ado, I'll turn it over to Travis to kick off our presentation.
Thank you very much, Melissa. I appreciate that. Good morning or good afternoon to you, depending on where you're joining us at from across the United States of America. We're very happy to have you with us today for this webinar that we think will be very informative and hopefully answer some of the questions or concerns that you may have about screening and assessment of persons with behavioral health disorders in the justice system. We have 4 primary goals for today's presentation. I'm confident that we'll probably accomplish more than these 4 goals, but at the very least we want to address prevalence issues related to co-occurring mental and substance use disorders in the justice system. We want to highlight and discuss the differences between screening and assessment approaches for persons with co-occurring disorders. We want to offer some examples and also provide you with resources that you can go to look at evidence-based instruments for use with justice-involved people. And then finally, we want to highlight the importance of screening and assessment across multiple intercepts in the justice system. And certainly with this, we'll be talking a little bit about the Sequential Intercept Model and the 6 intercepts that are a part of that model. One of those resources that we want to make you aware of if you aren't already, and we'll make sure that you have access to this link so that you can go to the SAMHSA store at the conclusion of the presentation today. The way that the WebEx event is set up, you won't be able to click on it right now, but we'll make sure that it is available to click on at the end of the presentation. This report on screening and assessment of co-occurring disorders in the justice system, what it really does is provide evidence-based practices for screening and assessment of adults in the justice system with mental illness, substance use disorders, or both. And the report discusses the importance of instrument selection for screening and assessment, and provides detailed descriptions of those recommended instruments. And again, we'll be touching on some of those today, but certainly more detailed information can be found in this report available on the SAMHSA store at the end of today. So just how common are mental and substance use disorders in the justice system? perhaps locally where you work at, as well as in a larger state system that you may be a part of or that your local system feeds into. We always want to do a comparison to the general population outside of the criminal justice system. And what we see is a 5% prevalence rate for persons in the general population when it comes to serious mental disorders, sometimes referred to as SMI. These would be disorders that would comprise things like major depression, bipolar disorder, schizoaffective disorder, post-traumatic stress disorder. So when we talk about serious mental disorders, we're not talking about people who may have situational anxiety or some sleep problems or situational depression, things like that. These are very serious mental health issues that people oftentimes need intense and extensive treatment and or medications to help deal with these disorders. When we move away from the general population and that 5% prevalence rate, what we start to see in our local jail systems is that overall approximately 17%, or about 1 out of every 6 people who enter into our local jails, are dealing or have been diagnosed with a serious mental disorder. And you can see the breakout here between men and women, 15% males and 31% females. What we often see is that the reason that number settles in around 17% overall is because there are more men than women who tend to be incarcerated in our local jail systems. When we move into the state prison systems, we see that that number settles in around 16% of men and 24% of women who have been diagnosed with serious mental disorders in those systems. So you can see that the prevalence rate really jumps from the general population as we move into our local and state justice systems. So if we break this out a little bit further in terms of the prevalence of specific mental disorders for justice-involved persons, we can see across depressive disorders here, when we compare the general population at 7%, that number jumps threefold to 21% of persons in the justice system with depressive disorders. The next two are somewhat, I don't know if I want to say staggering, but just the jump from the general population to justice-involved persons is pretty radical, very significant here. So what we start to see with persons with bipolar disorders is that number increases almost 24-fold as we move from the general population into justice-involved populations. As we look at persons diagnosed with schizophrenia, again, we look at a 10-fold jump of about 0.5% of the general population to 5% of those persons that are justice-involved. And then finally, greater than 2 times jump from 9% to 21% when we look at post-traumatic stress disorders. The reason that PTSD becomes so significant within justice-involved populations is that we've seen a lot of research that has come out in publications such as those by Truman and Morgan in 2016, or the Centers for Disease Control in 2016, and even trauma studies that we have done at Policy Research Associates, which really looks at the high incidence of trauma due to things like physical abuse, sexual abuse, and other abuses of persons who are justice involved. So it's not surprising to see that at minimum 1 out of every 5 people entering into the justice system has not just a history, but a significant history of trauma and diagnosable PTSD. When we start to move away from just focusing on serious mental disorders and look at the prevalence of co-occurring disorders in the justice system, we see that 74% of justice-involved persons with mental disorders also have substance use disorders. And you can see the breakout here of persons with using alcohol and other drugs, and then either or a combination of both. When we move over to persons who do not have a diagnosable mental disorder who are justice involved, we can see that approximately 36% of the population entering the justice system has a substance use disorder related to alcohol, 43% related to drugs, and then 56% either. So we're really talking about a significant public health issue when it comes to this topic and persons who are justice involved. And we need to take a very serious approach to this when it comes to screening and assessment, and then what we do with that information to help people with needed treatment, whether that's while they're with us in the justice system or as we're starting that process of reentry as the person is coming into the system. With that, I'd like to turn it over to Dr. Peters.
Hi there. It's good to be here today. Thank you, Travis, and thanks very much to Melissa and Roxanne for the introductions. It's great to be here on today's webinar. We're going to look first at just some outcomes very briefly related to co-occurring disorders in the justice system. If you'll bear with me, I'll move through some of these slides a little more quickly because they're fairly basic, and we'll spend more time on some of the others. So let's look at some of the outcomes for this population, and again, probably well known to most of you. This is a group that cycles rapidly through the justice system and other social service systems in our country. In each jurisdiction, they're well known to judges, probation officers, people at CSUs, ERs, etc. They tend to stay in jail longer and get longer sentences, both in detention and prison settings. They don't have money to bail out. They're perceived as more dangerous, perhaps, and so they tend to stay longer in incarcerated settings. When they're on probation and parole, we find, or pretrial release, we find that these individuals also have higher rates of technical violations. And of course, this often leads to incarceration in many settings. Also, this is a group that's characterized by high rates of victimization. So in contrast to the myth that the mentally ill or people with co-occurring disorders are more dangerous and violent than others, in fact, they're far more likely to be the victims of violence. In fact, 3 times more likely. As I think is known by participants, this is a group that are placed in isolation, solitary confinement more often than is typical. They're partly because they're preyed on by others, but partly because of behavioral cognitive issues that interfere with their housing situations and socialization in incarcerated settings. So as we also know, placing people in isolation in these settings is counterproductive and oftentimes augments the mental disorders among this population. Also, one thing that's not mentioned here that is commonly known, I think, is that this is a group that has higher recidivism rates following release from custody. They're often homeless and have few support networks. Oftentimes they're difficult to engage in treatment. And so really a whole range of issues that lead back to the point of that this is such an important target population to provide effective screening, assessment, and treatment interventions. So we'll move to the next slide. Very briefly then, what leads to the poor outcomes in the justice system among this population other than the major disorders? It's well known that these individuals are oftentimes not engaged in treatment. Just a small percentage, as was mentioned earlier, are involved in behavioral health treatment for the co-occurring disorders. They oftentimes are not engaged in insurance, even if they're eligible. They don't have financial resources. They're unemployed or employed part-time in low-wage jobs. Homelessness is a huge factor among this population and one of the key kind of foundational issues that has to be dealt with before any effective treatment can occur. And then we mentioned before, few social supports, few skills related to employment, vocational skills. What's interesting is counter to what you might think, this population has very similar levels of antisocial, criminogenic belief systems, thoughts, and behaviors, as well as peers, as others in the justice system. And we'll look at the implications a little bit later. But in fact, the risk level for recidivism and for rearrest is as high or higher than other justice populations. And they particularly have high rates of recidivism and dropout of treatment within that first 90 days after release from custody or residential settings. So let's talk just a little bit in terms of the relationship between co-occurring disorders and crime, because I think it has some implications for how we conduct assessment and what we're looking for in our screening and assessment of this population. So I'm going to show you one of the color slides here, and I won't spend a huge amount of time on this, but the take-home message here, if you look down at the bottom left, you'll see that there's only 4% of cases in which people with major mental disorders are arrested where their arrest is directly due to the effects of a serious mental illness, SMI. Another 4% have indirect effects of the SMI, which are related to the arrest. So the overall picture, as you look at the top of the graph here, is that for people with a major mental disorder, only 8% of their arrests are directly attributable to or indirectly attributable to mental illness. So it's interesting. And so I think, again, there's a myth that mental disorders causes crime and recidivism, and we need to assess for other types of factors that are related to recidivism. And so that's what I want to address next. And this is a familiar slide for many of you who are have been working with the risk-need responsivity model, R&R model, which provides a blueprint for how to engage in good case assessment, treatment planning, case planning for this set of individuals. So these are the factors that independently predict the risk for arrest among individuals in the justice system. And what you don't see here is mental disorders. So mental disorders are not an independent criminogenic need or a risk factor. However, as we mentioned before, people with mental disorders tend to have lots and lots of these other risk factors, which place them at least the same risk level for rearrest, if not higher, than other people in the justice system. So given that, given the low relationship between mental disorders and arrest, but also looking at these other range of criminogenic needs or criminal risk factors, what are the implications for us in assessment and treatment? First off, as was mentioned by Travis and our Melissa and Roxanne, that many people in the justice system need treatment for both mental and substance use disorders. However, based on what we just talked about, treating the mental disorders is necessary but not sufficient to reduce recidivism. So again, mental disorders are not an independent risk factor. However, it's the humane thing to do, obviously, to provide treatment for these disorders, and perhaps as importantly, that mental disorders can undermine involvement in evidence-based treatment or other interventions to address the risk factors in the previous slide. So very important to address both sets of disorders, even though mental disorders are not an independent risk factor for arrest. All right, so assessment then should examine a range of risk factors for recidivism that we just looked at. I'm going to back up the slide just to look at these again. So assessment needs to consider each of these factors in addition to all the other psychosocial types of areas that would be looked at in a psychosocial assessment. I think this is one of the biggest gaps right now in substance use treatment and in mental health treatment that are fashioned for people with co-occurring disorders, that we don't look at these whole range of risk factors for recidivism and, as importantly, to provide interventions for these areas. So here's another idea, number 4, is that all of the services for co-occurring and mental health services should include a focus on these risk factors, including interventions that address these factors. We know from the research that the more of these factors that are incorporated into your treatment programs, the better the outcomes in a linear fashion, so that if you included all 8 of the factors that we talked about previously, that you would have a much better rate of reducing recidivism. You know, I didn't talk about number 9, but there's some evidence now that among people with mental disorders, having a post-traumatic stress disorder elevates independently the risk for rearrest as well. More evidence is needed on that. So one final consideration then is that I believe that all mental health treatment for justice-involved people should be designed as co-occurring disorders. And this goes back to the slides that Travis shared with you in terms of the high rates of people who have mental disorders in the justice system that have a co-occurring substance use disorder, about 75%. So given the high rates of the co-occurring disorders among the target population that has a mental disorder, each program that serves people with mental disorders in the justice system, I believe, should be co-occurring disorders capable and should be adapted so that there are significant interventions for co-occurring disorders and substance use treatment. So again, across different settings, whether it's mental health courts, residential treatment for persons with mental disorders or co-occurring disorders, a range of other settings, crisis stabilization. Also, what's not on here, another setting that I think is woefully inadequate in terms of the preparation for co-occurring disorders is forensic units. And that might be a forensic diversion program. It might be forensic hospitals. And I think you'll find that very few of those have evidence-based practices in place with trained staff that provide interventions for co-occurring. Anyway, I think there's some implications here for how we provide assessment and how we provide treatment. So let's look at some functional aspects of co-occurring disorders that, again, I think have impact for how we provide assessment and screening for co-occurring disorders in the justice system. And I'm going to go through this fairly quickly. These factors, I think you'll find, affect the ability of offenders to participate effectively in treatment and employment. They become the focal areas for assessment and treatment services. We provide interventions for these. We also want to assess for these areas of impairment, right, when we provide our assessments. Something else is interesting. These are not measurable by traditional instruments that we'll be talking about in just a few minutes. And so oftentimes we'll have to, in most cases, we'll have to observe and look for these over time to look at the level of impairment that affects their participation in treatment and other areas such as employment, education, other types of services. Clearly, these are also the targets of our interventions that we develop in our treatment plans, our case plans. And then finally, I think these factors, both on this slide and the following slide, affect how we provide assessment, treatment, and supervision. For example, how we provide sanctions and incentives, but also how we conduct our assessments. So, for example, for people with short attention spans due to a range of factors, including recent substance use, withdrawal, major mental disorders that affect their concentration, ability to concentrate over a period of time, we have to address how we conduct assessment a little bit differently. It may be that we have to divide our assessments into two separate sections so that we only take 45 minutes to an hour and then have a break, and perhaps the next day we follow up and complete the assessment, making accommodations for limited attention span. So again, these other areas, difficulties in verbal encoding among this population makes it difficult for individuals to comprehend, remember, and to integrate information over time. And so we have to repeat things. We have to provide multimodal kind of instructions on paper, verbally, et cetera. We have to be careful of these things as well. Disorganization in life activities. Let's go on to the other kind of factors briefly. Again, poor problem-solving skills and planning abilities is a hallmark, I think, of this population. Again, as we look at these factors related to impairment, cognitive behavioral impairment, I have to say that the population with co-occurring disorders in the justice system varies tremendously along these domains, right? And so we can't generalize and think that a person with a major depression and alcohol use is going to be equivalent to somebody with a major opioid use disorder along with paranoid schizophrenia. They're going to be very different across these different domains. But in general, these characteristics, I think, differentiate people with co-occurring disorders from those that don't in the justice system. All right, so the response to confrontation in stressful situations, I think that's important. I think we can assess for that again by observation over time, but definitely has an impact for people who have paranoia, intrusive thoughts, perhaps fragile ego defenses, and lack of self-efficacy and self-confidence that may affect their ability to participate in group treatment or, for example, in a drug court, to have a meaningful conversation with a judge at the bench. Other areas here, we'll just note at the bottom that people's functioning tend to be worsened when they have the other type of disorder, whether it's mental disorders or substance use disorders. So when you have both disorders present, you have potential for a much worse set of level of functioning for this population. So again, just some areas to consider in the assessment process, but ones that aren't measured easily by assessment and screening instruments. So let's look at some of the instruments and how we approach this. And again, today's webinar, we're giving you a snapshot of some of the approaches and some sample evidence-based instruments that you might consider in your settings. So just very briefly, these are some of the reasons we conduct a comprehensive evidence-based screening and assessment for co-occurring disorders in our settings, not only the high prevalence rates, but the implications and consequences for people who are undetected with these disorders that end up coming back into the treatment system, into the justice system over and over again because they're not treated adequately due to the fact that their disorders are not identified clearly. When we conduct a good screening assessment, we can quickly place people in the right level of services that address the risk factors for criminogenic needs that we talked about, as well as other psychosocial factors. And we know that when we have a comprehensive assessment for co-occurring disorders, this leads to better outcomes among the client population. So real quickly, I'm going to not spend a lot of time on this because I think people are pretty familiar with the differences here, but a screening is a really brief yes-no decision about whether or not there's a likelihood of somebody having a behavioral health disorder, whether it's a mental disorder, substance use disorder, a likelihood for suicide risk, other types of things. But it's basically just a quick 5 to 8 minutes is typical for administering a screening. Typically, you don't have to have a lot of training. You don't have to have licensed or credentialed staff necessarily. It'd be advantageous, of course. Also, these are inexpensive approaches, and so there isn't a good excuse, I don't think, for providing universal screens that we'll look at in just a minute for the different areas that affect treatment planning and affect recidivism risk. So again, screening will assist in identifying people early that have a need for more comprehensive assessment. The downside, of course, is it's just brief and it doesn't really yield a set of information about which modalities of treatment or level of or intensity of treatment that's needed for a particular individual. It just gives you an impression diagnostically of what the major needs are so that you can conduct a more comprehensive assessment in that particular area. Assessment then following is much more comprehensive and lengthy, and in contrast to screening, we want a licensed clinician providing this who has knowledge of withdrawal, motivational interviewing skills, MET, basic interview skills, and of course knowledge of co-occurring disorders and the treatment that's available. Assessment is, as mentioned, a lengthier process, usually done by an interview, whereas a screen could be done by computer or by a paper version oftentimes, as well as in a group setting or individual setting. But the assessment is done typically with a one-on-one interview. So again, the assessment would yield a diagnosis as well as determination about the appropriate level of care, intensity of treatment, modality of treatment that's needed, and allowing us to develop a case plan or treatment plan for the individual with co-occurring disorders. For co-occurring disorders, an interesting aspect is that the assessment should really examine the interactive nature of the two disorders. So we want to look at, for example, periods of abstinence in the past and whether or not individuals were had had symptoms of mental disorders during abstinence, and it might be while they're in jail or prison. Did you continue to have the symptoms of mental disorders, which can be easily mimicked by any type of substance use? So we want to look in careful detail at that component as part of the assessment. So let's look at some of the instruments. I want to start out by saying that, again, screening is pretty easy to conduct. It's very inexpensive for the most part. If you're paying a lot for a screening instrument, you're probably using the wrong instrument, in my opinion. But there's a lot of public domain instruments out there, and we'll share with you some examples of these in just a minute. But these are the areas that I recommend that are included at each major step in the justice system. And Travis will go into these in terms of the intercepts. So, of course, mental and substance use disorders. Trauma and post-traumatic stress disorder is another area. Because of the high prevalence rates, we need to have screens for these disorders. And we'll talk a little bit more about the implications of not screening and identifying PTSD and trauma history among our population. Criminal risk we talked about as well. Very important to provide a screening and assessment for that as well. And then suicide risk. This is a group, the individuals with co-occurring disorders, no surprise, have a much elevated risk for suicide as compared to other people in the justice system. And of course, the stress of initial incarceration or post-arrest or at reentry, the stress levels are very high for individuals with co-occurring disorders, and the risk for suicide is elevated for this population. So these are really, ideally, you'd have a screen for each of these areas as people enter the justice system and perhaps move to different parts of the justice system, such as jail or prison or reentry. What are some of the other screening targets? We mentioned some of the universal screens that should be applied at these settings, but there's other screening areas that are also critically important. One is withdrawal severity from alcohol and opiates. And we'll look at just a couple instruments in a minute that can screen for this. And we'll also look at eligibility screening for medication-assisted treatment, which goes along with the withdrawal and also opiate and alcohol use syndromes. We want to look at major medical problems as well. And then below you'll see some of the other kind of areas that each of these, I would say, are what are called responsivity factors. There are potential barriers that can undermine engagement in evidence-based interventions to address co-occurring disorders in the justice system, and that the interventions that would otherwise reduce the risk for recidivism. So each of these factors, if not addressed in your screening and assessment processes, can undermine effective involvement in evidence-based interventions for our population. So let's look at a couple aspects of these here. So screening for withdrawal severity, there are some instruments out there, and I'm not going to go into detail, but can certainly address any questions you have. These are available online. They're free of charge, and they're relatively quick to administer. They're basically observational symptoms related to withdrawal from both opiates and alcohol that help us to guide the dosage range for withdrawal and induction, for methadone, Suboxone, Vivitrol, et cetera, and really important to use. Again, they're public domain instruments here. Just quickly, this is a lot of information on one slide. Wow. So intake assessment strategies for opioid use disorders specifically. And so I think there are some unique aspects of intake and assessment for this population. And I'm not going to go through all of these, but certainly this is a population that has a lot of distrust for treatment and has a lot of shame and guilt and have to be treated very carefully as they come into our programs with a welcoming attitude. We want to acknowledge that their symptoms are normal for individuals going through withdrawal. There is a time period in which they can expect improvement and so forth. We oftentimes have recovery support specialists that have been through this process themselves and can speak from lived experience. All right. Education certainly about medication-assisted treatment at this point, looking at what the advantages are, what the options are. You may want to delay assessment if we have an acute intoxication before we can gather accurate information historically, right? People aren't good historians if they're in the throes of withdrawal and they're distracted physiologically, cognitively by the withdrawal process. All right, so I'm going to move on. So let's look at risk screening, risk assessment. As many of you know, that there's been a lot of advances in the last 10 years in developing a set of standardized and evidence-based risk screens and risk assessment instruments. And it's beyond the scope and the time that we have available today to go into detail on these different instruments. But I want to mention that risk screening, there's a set of brief instruments that look at both static and dynamic factors. Static being primarily criminal history variables, such as the number of prior felonies and convictions, age at first arrest, and technical violations on probation, for example. Dynamic factors are the ones that we looked at in one of the slides, looking at the criminal risk factors. And so those are things like criminal thinking, criminal peers, criminal belief systems, substance use, employment, education, leisure skills, and perhaps post-traumatic stress disorder for the mentally disordered population. So a screen really just yields a very basic, rudimentary kind of category of low, medium, or high risk. It doesn't really tell you the level of services nor the modality of treatment that would be needed, but would give you a brief estimate of the risk level. The risk assessment, on the other hand, goes into a lot more detail. It's typically 45 minutes to a bit over an hour to conduct, and includes archival information about criminal history, but also a set of interview factors that go into things like criminal thinking and the other domains, employment, education, substance abuse, related to static and dynamic factors. The risk assessment gives you a profile based on those criminogenic needs that we talked about. And the usefulness of the risk assessment is it gives you somewhat of an independent type of treatment plan that would address factors related to future arrest. So generally the instruments will give you a profile, and you can then target your interventions on the high-risk areas that are represented in the profile developed from the risk assessment. So if I had a client who had high risk in substance abuse and criminal thinking, but was low on most of the other domains, I would focus my energy in the treatment program on those areas, in addition to mental health areas related to the co-occurring disorders. So very useful to conduct a full risk assessment for individuals. All right, so some considerations in screening for co-occurring disorders. I'll go through these fairly briefly. We don't want to exclude people from programs based on just the diagnosis, but it's much more important to look at the areas of functional impairment than diagnosis. So somebody can have a diagnosis of depression. They might be a CEO of a major company in the U.S. and be functioning pretty well, holding, obviously, having family, a job, and so forth. Other people with major depression may be in a vegetative state and be using drugs and alcohol and be in a totally different level. So the diagnosis doesn't really tell you whether or not someone needs a particular level of intervention. We really need to look at areas of functional impairment that we discussed earlier. One thing that we want to be careful of is not to use screening in place of level of care assessment. And I've seen this in certain cases where people provide a screen and then they place people in residential or intensive outpatient or regular outpatient treatment based on that screen. And that is not good practice. We need a more comprehensive assessment to do this. So just a caution. Another caution is that we have certainly substance-induced mental disorders, so that substances, as mentioned earlier, can mimic all major mental disorders. and that a recent use or withdrawal syndrome also can mimic major mental disorders. For example, withdrawal from lots of different substances can lead to depression, anhedonia, sleep disturbance, agitation, other physical symptoms as well that may look a lot like major depression, something else. So we have to be careful of that, and that we want to make sure that we allow enough time for people to detox from whatever drugs or alcohol they've been on to make sure that we have a bona fide diagnosis in the area of mental health. Again, so rescreening is needed after the period of detox and medical withdrawal, stabilization of the mental health symptoms for that purpose. One thing I will mention here at the last bullet is really interesting. We want to re-administer the risk screening and risk assessment over time. And typically this is done 6 months or longer after the initial risk assessment is done, because risk factors can change. And if we have people provided appropriate interventions, their risk level actually goes down, right? And so we can place them in different types of interventions. They may not need as intensive level of services for criminal thinking or for substance use disorders. And so we can then allocate those scarce resources to other clients who are more in need of those. So really important to do that. Also, it allows us to place them in different levels of supervision, regular probation, for example, versus intensive probation supervision. Just some considerations. Other types of things to think about then in terms of selecting instruments. We want to use standardized instruments that are reliable and valid. And so you want to look for the psychometric properties of instruments to make sure they're accurate, and that when administered over time by the same person or by different staff at the same time, they would provide equivalent outcomes on the instruments, the same type of scores. How easy are the instruments to use? What are the training requirements? So as we investigated some of the risk assessment instruments here in Tampa, Florida, recently for one of our projects, we found out that one of the public domain risk assessment instruments was actually more expensive because of the training requirements and cost involved with the training than one of the commercially available instruments. So it's important to look at these practical factors, the costs, how available are the instruments, what are the training requirements, is training accessible for your staff? Can you do that remotely, for example, versus having somebody come in and provide an expensive training or going off-site for that training? Then finally, a lot of instruments haven't been used in criminal justice settings. And so you want to check and make sure that whatever instruments you're using have been validated in those settings. I'm going to share with you and you have the slides. Without going into a lot of detail, there are a number of primarily public domain, free of charge instruments. Most of these are available on the internet that look at the different areas that we've talked about today. So in the mental health area, these are some of the key instruments that are used widely around the country, some outside the country, that you could that are brief again, somewhere between 8 and 18 items for these 3 instruments that are validated in the criminal justice system. These can be self-administered or conducted in group settings. Similarly, for substance use, there's wide range here. Some, the audit on the right-hand corner is just for alcohol use, but the other instruments, the assist also, the other 3 instruments are really multi-substance instruments that look at a range of factors, range of types of substances, and give a score that, again, is a diagnostic impression, not a ironclad diagnosis of a substance use disorder. But the TCODS here on the lower right is perhaps the most widely used instrument right now in the criminal justice system as a substance use screener. But all of these have good psychometric properties. Screening for co-occurring disorders. Now, you can pair a mental health screen with a substance use screen, and you've got a co-occurring disorders screen, right? So that's not rocket science. There are some so that one example of that is here on the left-hand side. We're pairing in this case, the correctional mental health screen and the TCODS 5 screen that is based on DSM-5. On the right-hand side, you have a single instrument that looks at both sets of disorders, a mini screen. And this is one that is not public domain. It has a small cost attached to it, but it looks at both sets of disorders. So screening for trauma and post-traumatic stress disorder, I mentioned this. I'm not going to spend a lot of time on this, but because of the high rates of these disorders, we really need to have a screen for this. Over 75% of female offenders have a trauma history or post-traumatic stress disorder. And interestingly, among males, the rates are over 50%. So oftentimes trauma is overlooked, and the symptoms are misattributed to perhaps low motivation, hostility, depression, and again, without identifying the trauma history accurately, we can really lead to some potentially serious consequences adversely for treatment. All right, just some other hints here that for how to conduct the screening. There's lots of non-proprietary screens, public domain screens. We'll look at these in just a minute. So here they are. There are basically three types of screens and assessment for trauma. If you look at the upper right-hand corner, you'll see the initial type of screen is for the set of events that may have caused the trauma, the current post-traumatic stress disorder, or other mental health symptoms. And so these would be instruments that look at a range of historical events that have occurred in the client's life that have led to the current mental health symptoms, such as the post-traumatic stress disorder. Then you have on the lower right corner, you'll have a couple of instruments here that look at the symptoms of post-traumatic stress disorder. So the one that's used perhaps most commonly, I would say, is the PCL-5, developed by the VA system, and a very brief screen that mirrors the diagnostic criteria for PTSD. And then you have more full-blown assessment instruments that are represented here as well for post-traumatic stress disorder, trauma-related disorders. So just a hint on if you want, and again, in the monograph that Travis had referenced, there are full descriptions of each of these instruments, the cost, how you obtain them, what are some of the comparative advantages of one versus another, some of those things. I mentioned we don't have a lot of time to go through the risk assessment instruments today, but there is a really good resource that is listed here on your screen, and I think there's a web link here to the monograph that goes into detail about some of the different instruments. Finally, I want to recap with just the domains that need to be covered within a co-occurring disorders assessment in your settings when you get to that point. And again, looking at functional impairment, risk assessment, interactive parts of the disorders, and the other factors here as well need to be covered in. And I think, as you can tell, the assessment for co-occurring disorders is going to take a little bit more time than a regular psychosocial assessment for a client without both disorders. Finally, and the last thing I'll mention here is there are instruments that do look at both sets of disorders. If you want a co-occurring disorders assessment instrument, here are a range of them that you could consider. So I'm going to end there, and we're going to turn it over to Travis to wrap up. Thanks very much.
All right. Thank you very much, Roger. I appreciate that. You've given us a lot to think about and a lot to digest here. And you know, when you're speaking, Dr. Peters, there are some thoughts that come to mind about jurisdictions that we have worked with, whether that's in the process of doing sequential intercept mappings, and we're going to get ready here as you see the slide about where should screening and assessment occur in the justice system. And the simple answer to that is basically everywhere. But some of the common challenges that come up across the 6 intercepts, you know, there are over 200 of you on this webinar today. And I'm sure across your jurisdiction, some of you are probably sitting there listening to what Dr. Peters and myself have said and thinking to yourself, we do a really good job with screening and assessment. We're very thorough at the 6 intercept points, or, you know, very thorough at 4 of the 6 intercept points. And there are others where, you know, some of this is brand new information, and you may have a lot of questions about some of the screening instruments and how that leads to subsequent clinical assessment and so forth. That can feel overwhelming in and of itself. You know, as Dr. Peters is showing, all the various instruments are out there, and we're talking about the monograph that we'll make available to you through the SAMHSA store at the conclusion of this webinar. It is not uncommon, unfortunately, when we go into jurisdictions across the United States and have questions about why are you not utilizing some sort of a standardized screening instrument at this intercept? Unfortunately, it's not an uncommon response for some people to say, because if we find something out about a person, if we find that there's something going on, then we have to do something about it. And oftentimes that can be a financial resource issue, it can be a human resource issue, it can be just a lack of resources in general. And we don't want that to be an excuse for jurisdictions to use to do good screening, because that can occur at any point across these 6 intercepts that you see up here on the screen right now, from intercept 0, where a person may be in crisis in the community, to intercept 1, where there's law enforcement contact with an individual who might be at risk for moving into the justice system, or at intercept 2, when we look at what happens at that point of initial detention or booking into a local jail, and then subsequent court hearings that happen pretty quickly after that initial detention. There's screening and assessment that certainly occurs in the jails and courts when we know a person is going to stay in the criminal justice system or in the local jail for a longer period of time. And we might be looking at things like a drug court or a mental health court or a veterans court. And then just as importantly, what happens at the point of reentry from our local jails, or as a person might move from the jail and into the prison system, and then finally back out to the community, oftentimes under the supervision of probation or parole. So we don't want this to feel overwhelming, that because you may feel like you have a lack of resources at your point in the justice system, that good screening and assessment can't occur, because it's needed. If you're a person on this webinar today who holds dearly the belief that we have too many people with significant mental health issues and co-occurring disorders in the justice system, and that the best outcomes for people are to connect people with the right services, treatments, and supports in the community, then this webinar is something that we hope that you'll embrace. And if you feel like you're in a jurisdiction that isn't really doing a good job right now with screening and assessment, that you'll ask your questions, or you'll link to these resources and utilize them at the conclusion of this webinar. So I just got done talking about on the previous slide, which I'm going to flash to again, about why early detection is important at each of these 6 intercepts. And you can see up here the sequential intercept model itself, and the model that we use to do sequential intercept mappings with when we go into a community. But you know, the short answer again to that question is good screening and assessment is needed at all 6 intercepts that you see on the screen right here. So in intercept 0, what do we commonly see as I reflect back on what Dr. Peters has shared with us this afternoon? You know, again, this is where you can see on the box up there that's on your screen where it says community on the left-hand side. We're going to start in the community in intercept 0, and we're going to end once again in the community when we get to intercept 5. But oftentimes at this point, you know, what we're trying to find here is there a way for people who are in crisis to access community-based services without first having to dial those numbers of 911? Sometimes that's not always possible, but it's important that a jurisdiction has a good idea of what services are available in that crisis care continuum, and do people know how to access them, whether it's themselves, family members, friends, and loved ones in that moment of crisis. And so the list of first responders that you see up there, EMS, fire departments, mobile crisis outreach teams, and crisis phone lines, you know, is there good screening, valid and reliable screening that's being utilized at intercept 0 by people who are going out? You know, we see great data where there are teams made up of law enforcement, of EMS, and of mental health providers that will go out and meet a person in the community in crisis, and that EMS provider has admitting privileges to local hospitals, so that way that law enforcement contact or further involvement in the justice system can be circumvented in the first place. But obviously that requires good screening and further clinical assessment to happen. And then what happens at the point if a person walks into a local hospital or a crisis stabilization unit? Are they providing good on-site screening, which leads to further clinical assessment too, with some of those instruments that Dr. Peters highlighted earlier? So as we move into intercept 1, away from intercept 0, really we're at the point where the individual who's in crisis is having contact with a law enforcement officer. Sometimes that happens through a 911 call, or perhaps in intercept 0, a local crisis line, and then was transferred over to 911. And we see that there are different types of responses here, but oftentimes when we have law enforcement involved in Intercept 1, we don't see too many law enforcement organizations that are using some kind of a structured screening instrument as they are going out on site. They're observing acute symptoms in an individual, and then they are making referral to specialized teams such as crisis intervention teams. Maybe they're bringing another law enforcement officer on the scene who's had specialized crisis intervention team training. You know, we're seeing some jurisdictions like very large law enforcement organizations in Honolulu, Hawaii, that are starting to bring up CIT, or those in St. Tammany Parish in Louisiana, Huntsville, Alabama, Alamogordo, New Mexico, that are really embracing things like crisis intervention team training or mental health first aid training to have their law enforcement officers trained well enough to know where to take people to try to avoid that booking into the local jail system if it's possible, or to activate some of those mobile crisis response resources or peer specialists that might aid in moving a person back towards Intercept 0 instead of moving forward into Intercept 2. But again, that good observation, screening, and then ultimately further clinical assessment to help individuals. As we move into Intercept 2, you know, we're really hitting that point at the booking desk where we want to see the utilization of those good, valid, and reliable standardized instruments that, you know, as Dr. Peters pointed out, that are available in the public domain for free. And there are plenty of them out there for our local criminal justice systems to utilize instead of trying to throw together a few questions and create a homegrown instrument that has not been measured for validity and reliability. But the goal here is to quickly determine the eligibility for early exit from custody and acute needs. This is where jail diversion begins to happen here at Intercept 2. And oftentimes that point of initial detention to when a person has their first court appearance happens in a very quick period of time. In some jurisdictions it's 24 hours or less. In others it's 48 to 72 hours. But this requires the gathering of good information on an individual coming into the system who may have a serious mental health issue, a co-occurring substance use disorder, so that further clinical assessment can take place and recommendations for diversion can occur. So we see these screenings being done by jail booking staff, by pretrial services officers that are brought in before that first court appearance, and then information being shared with the court clinics and diversion programs. A jurisdiction that's doing a really good job with this is in Johnson County, Kansas, where they're using the brief jail mental health screen to not just screen people for potential further assessment needs related to mental health issues, but they are beginning to really take the data from that brief jail mental health screen and identify peak booking times of people with potential mental health issues. What are some of the common charges that people who screen positive on the brief jail mental health screen are coming into the jail with? The brief jail mental health screen is being used to then send an automatic notification to a place like the Johnson County Mental Health Center once an individual is getting ready to be released from jail, so that a follow-up can occur, especially if they are not currently a client of the Johnson County Mental Health Center. So we begin to see here at this intercept how the utilization of good screening instruments can really assist a person with reducing recidivism rates and getting connected to the right treatment services and supports as they move through the intercepts of the sequential intercept model. In Intercept 3, it shouldn't be any surprise to us here that screening and assessment is imperative, especially as we start to look at diversion opportunities in Intercept 3 there under dispositional courts or specialty courts. So what type of screening information can we gather that leads to further clinical assessment that might lead to a recommendation for this person is an appropriate candidate for something like a substance use court, a drug court, a mental health court, a veterans court, a DUI court, the list goes on. And how can we share that information in an appropriate way to make sure that we're not only getting the person connected to the right specialty court, but that they're getting access to the right level of care. As Roger said earlier, we don't use screening instruments to determine clinical levels of care for people to be in. That's where good further assessment and evaluation comes in. But we need those screening instruments to say, yes, this is a person who is in need of further clinical assessment at this point in the criminal justice system. In Intercept 4, we certainly hope that this is not the first point where we're beginning to utilize screening and assessment. This should have been used early on in the Intercept model to begin for that reentry planning, or if we know that the person's going to be going on into the prison system and eventually maybe they're going to be out on parole or released from the prison system, what are their ongoing service needs? But how do we take this individual that's sitting before us who may have been involved in services in the community already, continue that linkage with a service provider while the person's incarcerated, and then begin that process of discharge or reentry back into services here in Intercept 4 as a person's coming back into the community. As Dr. Peters said, something that is really important here is we want to continue to reassess criminal risk because we want to know what are some of those criminogenic factors, and those 4 big ones all seem to have the word antisocial in it. But what are those criminogenic needs? And is the person connected with a provider that's able to adequately address some of those criminogenic factors with the individual, even beyond things like substance use or employment, education, things going on within the family, but to address perhaps some of that criminal thinking that's accompanying the mental health and or substance use disorder. So good coordination is imperative here through the utilization of screening and assessment. And then finally, as I promised you, if you look on the right-hand side of the box in Intercept 5, we've once again worked our way back into the community under the auspices and supervision of community corrections with the goal of determining the type and intensity of supervision and service needs. We know that we have very stretched resources when it comes to parole and probation, and so we want to make sure that the level of supervision that a person is under is really matching that need for the supervision. So as Roger talked about earlier, when we look at risk, need, responsivity, we want to make sure the type of services that the person is involved in is appropriate based on good screening and assessment, and that they're also being linked up with the right level of supervision based on those criminogenic risk factors. And again, that doesn't happen without the utilization of some of those screening instruments and further assessment, as Roger pointed out earlier. So what are the key points that we hope that you walk away with from this webinar today as we get ready to take a look at some of the questions that you might have? First off, it's that recognition that there are exceptionally high rates of persons with co-occurring disorders within the justice system. As you saw early on in this presentation, it's much higher than the prevalence rates that we see in the general population. That universal screening for mental health and substance use disorders, trauma, PTSD, and criminal risk is definitely needed. We can't just, again, throw together a few questions that we think are going to gather the information that we need, that we should be relying on evidence-based screening and assessment instruments that are available in the public domain. That early detection and triage is key. That way we're getting the person directed to the right resources, the right services, the right supports, the right treatment. And we're not just placing a person, and this is another gap that we see in many jurisdictions where we're saying, well, you know, we think this person has a substance use disorder and there happens to be a treatment slot available in this agency or a bed available here, without knowing if that's the right level of care for that person. So good early detection and triage is key, so we're not directing people to the wrong levels of care, the wrong services, the wrong treatments. And then finally, there's multiple intercepts for screening and assessment. And basically, that's all 6 of the sequential intercepts within the model that we can do a good job of this at. So with that, I'm going to go ahead and turn this back over to Melissa to kind of bring us through the remainder of the webinar.
Okay, thank you so much, Travis and Roger. So yes, now we have time to answer some of your questions before we conclude the webinar. And as I mentioned before, if you look on the right side of your screen, you should see Q&A. Just click on that, and the portal will expand, and you can enter in your questions there. So we really welcome you to submit questions for Travis and Roger. We had a couple of questions come in. I believe someone was asking where they could access the various instruments. And so as Travis mentioned, there is a publication. We'll give you an opportunity to download that at the end of this webinar. It's also available on the SAMHSA store. If you go to your favorite search engine and search SAMHSA store, it will pop up, and then you could search for the screening and assessment publication there. So that document will provide tremendous amounts of information regarding each of the instruments that we've reviewed today and more. And so by going through that document, you can find where to locate each of those studies or each of those screenings or assessments. It will share information about the validation of those instruments, as well as costs, if there is a cost associated. So please do look at that publication, and if you look at it through an electronic format, you can search for specific instruments, and they'll take you directly to the paragraph that provides information you're looking for. So there was a question about evidence-based instruments and the studies that are done on them. The types of studies, evaluations, and validation studies done for each instrument will vary, and we do provide more information about that in the publication. But Dr. Rogers, Dr. Peters, I just wanted to check with you. Is there anything else you want to say in response to that question regarding the types of studies that have been done on these tools that you covered today?
Sure. Yeah, I have a couple comments. One, just going back to your previous comment about the monograph and how to obtain the instruments. I think I mentioned at one point previously that you could actually do a search on the internet for most of the instruments that are described in the slides today and find those on the internet. Clearly the ones that you wouldn't be able to obtain copies of are those in the proprietary instruments that are at cost, although you could certainly locate how to order those or get a sample copy perhaps if the publisher is willing to provide that. So that is one thing to consider in terms of obtaining or looking at the different variety of instruments. In terms of the research on the different screens and assessments, I think one thing is that it's probably easier to conduct research on the screening instruments. For the most part, there is evidence also about some of the assessment instruments like the Addiction Severity Index as well. So it's the reason it's easier for the screening instruments is you're measuring the output from a particular screen in terms of the overall score, let's say, compared to a gold standard diagnosis of a substance use disorder or a mental health disorder, and then looking at the correlation between the score from the screening instrument and the score from the gold standard instrument, which is a diagnostic classification instrument. It's a bit easier to conduct. What's been done on the assessment instruments is to take a particular domain, such as, let's say, the substance use domain on the Addiction Severity Index, and to look at the equivalent gold standard instrument for that domain, which might be the SCID, a substance use module. So a couple of other comments, though, about the research. It's really interesting. There isn't as much research as you would expect in terms of comparative effectiveness of the different instruments. So what I mean by that is there are very few studies that look at how effective is the audit versus the MAST in identifying alcohol use disorders among the criminal justice population. Very few of those studies have been conducted. What you do find is a single instrument looking at the outcome in terms of sensitivity and specificity, the psychometric properties of that particular instrument in comparison to some other benchmark that would provide evidence, let's say, of a substance use disorder. So many more of those studies are conducted. I think there's just a lot more research that's needed to compare the effectiveness of the different instruments that we're talking about today against each other, head-to-head, but also in the area of interventions as well. You don't see that with different treatment, kind of manualized treatments for co-occurring disorders or substance use disorders or mental health disorders. So one last thing I'll share, and then I'll close, is that if you look at studies that are conducted by the proprietary interests of a particular instrument, the authors of a particular instrument, you'll find, as you find in any other area of scientific endeavor, that the individuals who originated the instrument or the particular kind of variable or concept that's being examined, you'll find a disparity between those that come later and provide studies of that same instrument. And so there is a kind of an inherent bias that we find in outcomes for studies that are conducted by the authors of a particular instrument. So I would just, and that holds true not only for our screening and assessment instruments, but also for the interventions, so the manualized treatments for substance and mental health disorders as well. So those are just the comments I would share, Melissa.
Thank you. Thank you so much. So we have a couple of questions about the implementation process. So one person asked, as a community provider who would like to encourage their current jurisdiction to implement the sequential intercept model of screening and assessment, who are the key people to reach out to and start conversations with? And I think both of you could respond to that. We'll just start with Travis.
Sure. I think, there's not a singular answer to that question. It's an excellent question, but it depends where you think in your jurisdiction perhaps that gap might be at, or which intercept the gaps are in. There are many. When we do a sequential intercept mapping, for example, there are up to 50 people that we bring into the room across those 6 intercepts, and each one of them is important based on what their role is in a particular intercept. So, for example, in Intercept 1 with law enforcement, it would be important to know what kind of training your local law enforcement agency or agencies are receiving. Are they doing the standard 40-hour CIT, crisis intervention team training, to recognize signs and symptoms of mental health issues, co-occurring disorders, other potential issues, and what services, treatment, support providers are they using to help with that further assessment based on perhaps some acute symptom observations that the law enforcement officer has. As you move into Intercept 2, it's really, really important to bring the jail into the mix. So you may have a jail administrator or somebody who's working with folks at the jail booking desk to identify, okay, what types of standardized screening are you using in Intercept 2? And just as importantly, and I really want to emphasize this because I don't know if I did enough during this webinar, is how does the information that is gathered at an earlier intercept, how does that get used in later intercepts? How does that get passed along to other system partners? Because the last thing that we want to do, especially for people with significant trauma histories, is have a bunch of strangers across the 6 intercepts asking them the same questions over and over again, when the reality is we have good information that's already been gathered at an earlier intercept. So, in Intercept 2, we want to look at what's going on at the jail, how is that being used by pretrial services and perhaps some of the system players in the court at that initial court hearing. What happens at the jail when a person's going to stay there longer. So your jail staff, your court personnel, your law enforcement officers, staff that are doing reentry perhaps out of the jail back into the community, and then finally probation and parole. So I would say if you could start with some of those partners, jail staff, defense attorney, prosecuting attorney, and judge who maybe are champions for this issue, as well as reentry staff and probation and parole staff, if you could start with that, half a dozen or so, you'd be well on your way.
I guess I could add a comment or two. Thanks, Travis. Really helpful information. I think one of the key things is what potential barriers are there to implementing a different type of approach to screening and assessment. And so I think you have to kind of do an environmental scan, I guess, of checking to see what is the motivation for change and feasibility for changing the process. I would say sometimes you find a lot of inertia and willingness to stay with the status quo approach towards screening and assessment. For example, there may be a homegrown instrument that's been developed and used, and people are quite satisfied with the outcomes, even though they haven't conducted research on that particular homegrown instrument versus other potential alternatives. And so I think you have to look at that first and see how you might generate some motivation for change. I think one way for doing that is to gather data, right? So that you might look, for example, at if you're interested in implementing a trauma screen, but there is none, and there isn't a lot of current interest in adding to the type of screens that are provided at booking, for example. And we all know time is of the essence, and there's not a lot of time available in some of these settings to conduct multiple screens. So what you might do is gather data on how many persons are falling through the cracks that aren't identified currently as having a trauma disorder, but that could be better identified by using an evidence-based screen. So I think you try to make a case for the benefits of doing that and looking at how the system could be better served by providing a more systematic approach.
All right. Well, thank you. I think kind of a related question, but it's different. Someone asked, is there a system evaluation tool / example to help communities assess the screening and assessment done at the different intercept points in their community? And I'm not aware of a tool like that, although it's not a bad idea. Travis or Roger, are you aware of anything that communities could use to kind of do an inventory of the types of screenings and assessments that are done at each intercept?
Let me start with that. My primary thought is going to be a simple one and a short one, is that I agree with what you said, Melissa. I'm not aware of a tool, so to speak, an assessment tool that looks at screening and assessment done at the different intercepts, but that's what we do when we come in and do a sequential intercept mapping. There are a lot of questions that we ask the criminal justice and behavioral health system partners throughout that mapping, and at each intercept we want to know and we want to inventory what types of screening and assessment is done at each of those 6 intercepts, who is doing it, is it standardized, is it not standardized, how does that information get relayed from one part of the system to the next part of the system. And so there are a lot of questions surrounding that are a part of a sequential intercept mapping process.
Right. Yeah, I think that's a really good set of thoughts. I think ultimately the goal would be to have a diagram, right, at whatever intercept you're interested in, and it might be across different intercepts, of what information is being gathered, how is it being collected, and then, keeping in mind in the background, are people using evidence-based instruments? How effective is this likely to be? But I think to have that discussion, as Travis mentioned, you need to have a set of actors in the room who are representing people who are gathering the information and actually doing the work to be able to tell you how that information is being gathered, processed, and how the information is being used.
Right, and I want to add that SAMHSA also has another publication that we call, the abbreviated title is Data Across the SIM, and going back to one of the important points that Travis made is there may be some intercepts that are doing the data collection and conducting the assessments, and that data could be pushed along and shared with partners later on in the sequential intercept model. And the publication Data Across the SIM provides some supports and some information in terms of how to facilitate that data sharing. So, for example, if you have a reentry specialist doing some assessments on people before they leave a jail or prison, what could be some ways that that information and data could be shared with probation and parole or community corrections. So that's another document that you could look for on the SAMHSA store, and we can send that along with the slides when they are ready. And just a couple more questions about tools. Someone asked, do you have any recommendations for screenings to assess for social supports, housing, et cetera? So I'll start with Dr. Peters if you have any recommendations, and then Travis if you have any ideas.
Yeah, so for social supports, and what was the other, housing?
Yes.
Or transportation? Yeah, so I think there are instruments out there. I'm not versatile in given you a range of different options. But I think there are a range of those for social supports. Travis, you may have some names of those as well. And, clearly there's been a lot of work in developing housing and support for transportation as well. So I think some of that could be done by checklist, but I think there's, particularly in the area of housing, there's some more detailed types of assessments that are available for those. So we can certainly provide those to the individual and look into that. But I don't have an answer in terms of specific evidence-based instruments that I could recommend at this point.
Yeah, and I don't either. I think in the monograph you might be able to find some information, or we can also be helpful in connecting you with resources such as the Corporation for Supportive Housing or other organizations that really specialize in these specific areas.
Yes, thank you. Oh, go ahead.
I was going to say maybe I could jump into Shannon Bryan had a part 2 to her question about are there examples of using the intercept model in the juvenile justice system? And yes, there are. PRA operates the National Center for Youth Opportunity and Justice, and one of the functions of that national center is to do sequential intercept mappings for local juvenile justice systems. So again, that's a resource we can help connect you with if that's something your jurisdiction's interested in.
Thank you for that, Travis. And the final question we have is someone asked how many screenings are reasonable to administer at one time? For instance, at booking, how many screenings would be reasonable to administer?
That's a good question. It depends on the jurisdiction in terms of how much time you probably have available. But I think at minimum, most jail bookings will provide a mental health screen. Because it's a constitutional requirement that services are provided for that. But I think certainly you're looking at a substance use screen at that point. I think the other one that you would want to look at is a trauma screen as well. And also for the suicide risk is often provided as a single question, but a more systematic approach is available through a range of different instruments that would offer a set of items from 6 to 21 items for some different public domain instruments for suicide screening as well. But typically the suicide screen is, it's not rocket science, and you're asking about whether or not people have ideas about hurting themselves, whether they have any, whether they've attempted suicide in the past or recently, those kinds of things. As well as looking at symptoms, obviously, of depression and cutting and other behavioral indicators. But I think those are the key areas. Travis, do you have any thoughts?
No, I would agree with you with those 4 areas, Roger, that, if you have an individual who's going to be with you for a period of time and you have the resources available to do so, I would start at the very least with a mental health and a suicide screen. And if what you're finding from some of those screens, that there's a need for further substance use as well as trauma, those are always highly recommended. So at least those 4 areas.
All right. Well, thank you. We've reached the end of our questions, and so now we just have a couple of wrap-up slides for you. One thing we promised was the certificate of attendance. So you should have seen a file transfer box pop up on your computer screen, and shortly you will see a certificate of attendance pop up under file name. What you do is you click on the document. So for example, webinar attendance, just click on that, and then the download button should turn a dark gray color. Click on the download button, and then that will allow you to save the publication or the attendance certificate directly to your computer. We'll also, you should also have seen the screening and assessment publication added to that file transfer box. So again, click on that file name and then click on download, and that will give you the publication that has been the inspiration for today's webinar. Alternately, if you would rather go directly to the SAMHSA store to save the product, the link is available on the screen again. And we have some upcoming webinars. As I mentioned, this is a part 1 of 2 webinars we're hosting on screening and assessment. Our next webinar is going to be focused, as Roxanne mentioned earlier during her opening remarks, this webinar is going to be focused on the practical applications, and we will be going through case scenarios to really explore how screening and assessment can be done in real time in various settings across the intercept models. And we have 2 more webinars coming up in December before we wrap up the calendar year. On December 11th, we are hosting a webinar on leveraging telehealth for justice-involved individuals, and that will begin at 1 p.m. And then on December 12th at 2 p.m., we will be hosting a webinar on family treatment court best practice standards. So we hope to see you join us for those webinars coming up. Also, if you haven't joined our listserv, we really encourage you to do that. We distribute a monthly newsletter with more information about various aspects of serving individuals with mental health or substance use disorders in the justice system. We feature various local programs and evidence-based practices in our monthly newsletters. This is also a way to get notifications regarding upcoming webinars and publications that have come out of SAMHSA. If you have any questions, a couple of you did ask for more information about different tools or ways that screening and assessment can be used in the juvenile justice system. So don't hesitate to reach out to us here at the Gain Center, and you see the information here at the bottom of this slide. We receive funds to provide phone-based technical assistance to jurisdictions across the country. So don't hesitate to call us or to email us through our website and let us know how we can help you more regarding these issues. Another way to provide feedback is you may have seen another poll pop up. And so hopefully you were able to participate in that. So we'll be taking this information and looking at ways that we can consider providing more information around this topic in a way that's helpful to you. So again, please don't hesitate to reach out to us here at the Gain Center if you have additional questions or need for assistance. And I just want to give Travis and Roger a big thank you so much for the information you shared today and taking the time to share your expertise with us here. So without further ado, thanks so much for joining us, and we hope to see you at our next webinar. Have a good afternoon.